Hello, everyone, and welcome to day one of Patient Congress. My name is Nicole Braccio. I am the Policy Director at National Patient Advocate Foundation, and I am so thrilled to be here with you all today. We will go through a few housekeeping items before getting started. But first, I wanted to thank all the participants for joining today, as well as our sponsors for making today's event possible. So thank you all. And we have a lovely agenda for you today, along with 2 more days following today. So just for some housekeeping items, we hope that you will stay engaged with us throughout the presentations. So if you have any questions, please enter your questions in the Q&A box at the bottom of your control panel. And note that closed captions are available for today's session. So please use the control panel to access that as well. And if you need help with that, or if you are experiencing any sort of technical difficulties, please do not hesitate to ask. It happens to the best of us. You can email us at npafevents@npaf.org, and someone will get back to you as soon as possible. And also, if we would love to know where you're joining us from today. Patient Congress has always been a very community-focused event with our volunteers at the heart. So we're excited this year, as well as last year, to invite additional partners to join our community. So please let us know. You can change your name in the Zoom. You can right-click on your name where the box where your face shows up, or at the 3 dots at that top right corner, and then select rename and give us your name and your state that you're coming from, or an organization if that's who you're representing today. And without further ado, the agenda will just give you a sneak peek of what that looks like. Today, we will have 3 sessions that you can choose to join. The first is our main stage session, where we will have our first panel on needs navigation. Then after that, you have the option to join one of 2 sessions. And then finally, after that, you can see here on the agenda on the slide, there will be our final session that we'll all come back together for. So we should be ending the day around 3:15, 3:30. And without further ado, I'm thrilled to announce and introduce our Chief Executive Officer of both Patient Advocate Foundation and the Advocacy Affiliate, National Patient Advocate Foundation, to kick us off for the rest of the day.
Wonderful.
Take it away, Alan.
Thank you, Nicole. Welcome, everybody, to Patient Congress, hosted by the Patient Advocate Foundation in collaboration with the National Patient Advocate Foundation. You're probably all tired of hearing this, but very sorry we can't all be together in person, but glad you could join us from wherever you are virtually. I'm in my kitchen in Yorktown, Virginia. So thank you again for spending the next few days with us. We're going to be talking a lot about social needs navigation, amongst other topics, throughout the next 3 days. At Patient Advocate Foundation, as many of you know, this is a service we've been providing since we began 25 years ago. It is the core of our organization, who we are, what we do, and how we learn from the patients we serve, particularly the most vulnerable patients suffering from all types of inequities in the healthcare system. So the one thing that you all probably should know the most is we call it case management. There's a lot of terms you could use to describe the service, but externally we're referring to it as social needs navigation. And one of the ways that we are trying to make sure that we establish the best standards and the best approach and the best way to scale social needs navigation is to really understand the science of it, what it means for patients, how to do it. We'll be talking a little bit about that throughout the next few days as well. But one thing I'm excited to unveil to you, and it's the latest and greatest thing from the Patient Advocate Foundation, is what we're calling the Patient Insights Institute. So you're privileged to be here at the beginning. We're launching this today. This is the official unveiling. And I'm going to turn it over to Dr. Rebecca Angove, who's our Vice President of Patient Experience and Program Evaluation, also the director of the Institute, which we just unveiled 30 seconds ago. And she's going to talk to you a little bit more about it. Thank you, Rebecca.
Thank you so much, Alan. Yes, this audience is the first to know about our Patient Insight Institute. We are launching officially today. We have just a few slides to introduce this newest initiative that PAF is working on. And we are going to touch on it a little bit more throughout the entire Patient Congress. But if we could just go to the next slide, I will get started here. So really the focus of this institute is to ensure that healthcare is informed by the whole patient, and specifically the diversity of patient experiences and voices that really have historically been underrepresented. We are going to empower and work closely with people and partners that want to improve access and affordability and really see the patient perspective as critical to informing change. This institute really builds on what PAF has been doing for 25 years, both the service, the experience, the data, the policy, the advocacy work. This institute is really a connector to help connect research, healthcare, and policy leaders to our population and the experiences of the patients that we serve and work with every day, specifically with access and affordability issues. And as you'll see through a few of the sessions over the next couple days, patient centricity is really becoming a critical component of not just care, but research and policy. And we're really supporting that and making sure that every voice from every different perspective is represented in those spaces. We're going to do this in a few ways. We're going to identify and prioritize patient and caregivers' needs and outcomes. And again, PAF and Npaf has been doing this for years. This is just a formal home and space for us to do this, both with our patient and caregiver partners, as well as our number of other stakeholder partners. We're really going to move and advance that next generation of patient-centered and caregiver-engaged health services research. So we're going to really make sure that not only is policy patient-informed and care is patient-informed, but research is as well. And we're also going to take everything that we learn every day and generate real solid evidence to help support policy and advocacy initiatives so we can drive change with evidence. So a few things to just be on the lookout for. We are working on the website. We are working on some resources. We're going to have project and partnership announcements, and we're also going to have opportunities for you to get involved in our great institute. So more to come. Thanks for the opportunity to let me share this exciting initiative with you, and I hope to see you all at some of our in some of our projects and involved in some of our initiatives. And I'm actually going to invite my colleagues now to join me because we are going to kick off today with a panel discussion on needs navigation and the path to health equity. So I'm going to have all of my wonderful colleagues join me on stage, the virtual stage. Alan is back. We also have Aaron Bradshaw, Shanta Chambers, and Rebecca Kirsch. So welcome everybody. And I see everybody on our virtual stage. So before we kick off this panel, we have a number of my colleagues on from the equity side, from the research side, from the policy side. And I'm going to do just a little bit of level setting and go through a couple slides before we start today. So just bear with me as I navigate technology in real time and share my screen. And I did this in practice, and now that I am being asked to do it in real time,
Rebecca, I don't think it would be a real Zoom conference if this didn't happen. So right on cue.
Absolutely.
I absolutely just did this in in that, like backstage practice. Okay. I got it, guys.
We have great faith.
Can you see it now?
Yes.
Lovely. Thank you. Thank you for humoring me. I need more coffee, apparently. Okay, so what I wanted to go through really just to set up this panel and this discussion was talking a little bit about both needs navigation and how it connects to social needs and social determinants of health. I want to make sure we're all on the same page. So when we talk about needs navigation, we are really talking about things that are outside but closely connected to a diagnosis. So this is a great infographic. On the left side, you have a diagnosis, medical treatment, the cost, the side effects, the clinical goals. And then there's everything else, that constellation of challenges and issues that come up around paying for food and utilities, managing that cost of care with some of those other cost of living issues, childcare, transportation to treatment, work disruption. And really needs navigation is looking at all of those challenges that arise from a diagnosis and finding ways and resources to support those needs that arise. So it can be anything from financial advocacy all the way to, very complex insurance enrollment, workplace services, other insurance support. So this is really what we're talking about when we talk about needs navigation. And that navigation is that one-on-one support to help patients and their families manage all the non-medical or medically related pieces of a diagnosis. And this financial distress, if you've been to any of my presentations or my colleagues, you have seen this data before. This is a reality. So not only are patients and their families financially stressed after a diagnosis, it's actually one of their top concerns at the time of diagnosis. We find, and this is data from our patients, that the overall cost of treatment is more concerning than long-term side effects, the possibility of dying, or short-term side effects. So this is a top concern and something that needs navigation really addresses head on. And so these are just a few things. I'm not going to read every one. I know everybody got the decks before we started, but this is what we know, right? So we know not only is financial distress and avoiding financial distress a top concern, we know that these financial and social needs are often overlooked aspects of the care that patients received, often not even talked about or addressed from the providers. And we also know that there is a need to ensure equitable access and care that starts with patient-centered, person-centered communication and the skilled care coordination, right? These are core competencies, and navigation support really supports this person-centered care and person-centered communication by helping providers address some of these social and financial needs. So these are things we know and PAF and Npaf has been working on for a long time. So let's inject this a little more complicated. So I would imagine that a lot of the attendees and the people on this call have heard of social determinants of health, right? Hashtag SDOH. And when something becomes a hashtag, I feel like people use it and often don't understand exactly what it is. It becomes one of those buzzwords. And so I wanted to just walk us through what social determinants of health are. So social determinants of health really are the social and economic conditions in which people are born, grow, work, live, and age that influence health outcomes. So you'll see in this graphic, this is education, healthcare quality, your neighborhood, where you live in your built environment, your social and community context, and your economic stability. And one thing I want to highlight is these social determinants of health are really shaped by the distribution of power, money, and resources throughout local communities and even nations in the world, right? When we talk about it, we really think, though, about local and state communities. And the difference in this money, power, and resources that are related to social determinants of health really lead to health inequities, which means different health outcomes. Because of these factors, patients and families living in these areas often have worse health outcomes than their counterpart that may be in more advantaged communities. So that's what social determinants of health are. Now, it gets a little more complicated because social determinants of health are a community or a state or even a national level when we talk about them. They lead to social risk factors. So these social risk factors are social conditions that are associated with poor health. So you as an individual or a community may have a social risk factor because of the social determinants of health, right? The distribution of power, resources, and money where you live. And that all filters down to this individual level, the social needs. And that's really what we're talking about when we talk about needs navigation. There's a lot that's being done on a policy level and a built environment level, addressing the social determinants of health. But what PAF does and what other groups that do social need navigation do is we address the effects of the social determinants of health, those individuals that have social risk factors and because of those risk factors are experiencing social need. This is really where the needs navigation comes in. It's an intervention. And a person can have many, many social risk factors, but fewer immediate social needs. So just because somebody has a risk factor doesn't mean that they're going to have a need in that area. And that's really why engaging individuals in conversations about their immediate unmet social needs is crucial to identifying what is most pressing at the time and how they can get the help, the resources that they need. And that's what needs navigation does. Needs navigation is also really important. You just heard me talk about the Institute and building evidence. As we help more individuals through needs navigation, we learn a lot. We start understanding the patient experience, how to better support patients and communities to address their social needs and those risk factors. And so we continue to learn about social determinants of health to work on those structural changes that we can do at a community level, and also improve the services that patients are receiving. So just a little briefly talk about PAF. We work with about 21,000 patients every year, and we provide screening and support for a variety of social needs, and this is similar to what other social needs navigators are doing. We have a number of contacts that we make with patients, and we spend a lot of time with our patients. And so again, needs navigation provides people with the resources and the care they need, but it also gives us an understanding of the experiences and preferences of patients struggling to navigate and afford healthcare. So once we start learning what that patient experience is, we can start putting programs and interventions and policies in place that can help patients address those social risks and social determinants. And then, there is a whole body of research and work that is focusing on what's most important to patients. And we only learn that by talking to patients. So again, learning from patients what their social needs are, the experiences that they're bringing can help inform research and truly move us towards a more equitable health system. That is the ultimate goal. So right now, the goal for both PAF and Npaf and what we're going to talk about in this panel is thinking about how do patients understand needs navigation so we can get the services into the hands of patients that need it the most, and how can we make sure that practice standards are being met. So how do we build that next that next the next approach to needs navigation. How can we continue to improve it using the evidence and what we're learning? So right now I am going to move into our panel discussion where we can really talk about making needs navigation a standard of practice, get it to the patients and the families that need it the most, and really standardize and scale the needs of navigation through research, public policy, advocacy, and grassroots mobilization. So I'm going to push us to my great colleagues. And Erin, I think what I'd love to start with you. And if you could just talk a little bit about how social needs navigation has evolved over the past 25 years that PAF has been working with patients and families. You've been at PAF from the start, and I'm sure you've seen quite the change from 25 years ago to now.
Yeah, thanks, Rebecca. I have been with the organization 23 over 25 years and actually started with direct patient services and supporting people through the phones and helping them navigate that, and certainly have seen the evolution, both positive and challenging, that has evolved based on supporting those that are dealing with complex and chronic conditions and the impact of their health has on their financial and access needs. I think the major, one of the things that I have noted is that we've had some significant shifts in what the financial responsibility is on the consumer or the patient, and the shift of access to the insurance products, how they're designed, as well as what the out-of-pocket expenses are associated to that. It's also, resulted in, in creative problem solving, and so over time we've had to really adapt or adopt different practices and solutions to help people navigate. And the most, we have to continuously educate ourselves on what's important, how to train our staff, as well as get up on top of trends or our focuses. Our patients lead us down what their most immediate needs are. And our whole goal is to help them through self-navigating, not only by influencing them and helping them get the support they need, but also teach them, because we recognize that health literacy is extremely important for them to be able to continue down this path. Navigation is a lifetime, even though they're reaching out to us at that most immediate need. And so, those are the areas that, we want to focus on is supporting them and really driving that, as well as building operations and building programs and supports, recognizing to meet those trends and goals, and then shifting to meet those accommodations.
Shanta, from a community perspective, where do you see the opportunities in needs navigation to really close those disparities experienced by limited resource populations? So kind of zooming out from that individual and into the community perspective.
Well, Rebecca, great question. And I think there are enormous opportunities, right? If we think back a couple of years ago, we were having similar conversations around patient navigation in the context of oncology and clinical care. And so we began to think about, we realized that not everyone interacts or interfaces with the healthcare system in the same way. And we know there are many factors that contribute to that, whether they're systemic factors, whether they're access factors, whether they're policy factors, whatever it is. And so some brilliant mind at that time said, well, what if we paired up an individual along their oncology journey with a navigator to really work with them from screening to detection, to treatment, to even survivorship. And we've seen the benefits of that really play out in terms of really helping to link populations of color, underrepresented minority populations, or what have you, to early cancer screenings and things of that nature. So we've seen the benefits of that. And it came from the fact that we realized that not everyone engages with the healthcare system in the same way. So it's important for them to have this quote unquote coach or navigator, this person right alongside of them to accompany them along their journey. Well, guess what? We found the same to be true with the onset of the actual COVID pandemic. What we saw on display was really unaddressed social risks that you highlighted in your slide. And so what we now realize is just like we know people don't actually engage in healthcare the same way. We know that people aren't connected to even social systems in the same way. But we also know that there's enormous contributing factors of unaddressed social needs in terms of their impact on one's ability to access healthcare, adhere to any level of healthcare, and survivorship. So this opportunity for us around needs navigation is very similar to what we learned in oncology. What if we are provocative enough to really design a system where we systematically identify those social needs that you identify and have a orchestrated way to help navigate and facilitate individuals and communities to a network of resources that respond to those identified needs. We have to understand if we're truly going to address health equity, if we're truly going to address disparities in healthcare outcomes, we have to make sure that we take into account the social context in which individuals live, because we know the consequence of not addressing these social needs will have implications on healthcare outcome and, unfortunately, even mortality.
So thanks, Shanta, and both you and Aaron really spoke to this being both a lifetime need for individuals and a pressing need that communities see regardless of condition. You know, you've seen it from the cancer diagnosis now, you know, through COVID. Does anybody on the panel want to speak to the challenges or opportunities for scaling social needs navigation as you see ahead? Because from what I'm hearing, this is something that is kind of just needs to be more widespread and available. We need to reach more people.
Yeah, I'll jump in there, Rebecca. So a lot of it was touched on in your slides, but I'll put a little more detail around it. I think you start with the idea of the reality that there are multiple types of navigation currently. And if you some of the more common terms like financial navigation, clinical navigation, and those two forms are usually tied very much to things within the health system still. So helping patients pay for their medical costs, helping patients understand their clinical journey and why they might need to have a certain diagnostic exam, or helping them coordinate between the specialists within their that are providing different levels of care, whether it's the folks doing their infusion versus the surgical and radiological interventionalists. So the challenge, and I bring that up because what we're talking about here when we think about social needs navigation, as we've already been indicated, is a whole panoply of issues that are often happening outside of the four walls of the health system, but are very much related to the outcomes of clinical care. And of course, the ability to afford care, access care, adhere to care. So that's the challenge to scaling. Is right now, a lot of the navigation world is fairly constrained to things that are still confined or able to be addressed within the health system. And when you open up the box to think about social determinants and unmet social needs, you really are talking about a lot of things that are happening outside the clinic. Therefore, you actually have to figure out how to get people help with those issues, which often means relying on an external partner, whether it's a community-based organization or a national-based organization like ours. That is a difficult step for some clinics and health systems to coordinate that outreach, that referral, and then making sure that that patient gets the help they need. So that's probably the biggest challenge. But as we know, if you don't deal with these things, it's a problem anyway. So you can ignore them at your peril, but eventually, for many patients, these problems do impact their care. So that's sort of the biggest problem to scaling, I would think. And that's one of the reasons why we as an organization really are in a really ideal position to understand the science of social needs navigation, how to do it, how to actually, what are the types of issues that really can be dealt with and should be dealt with by external actors in the, outside the clinic. And then there are some issues that can be dealt with by social workers and financial navigators and others within the health system as well. And that'll differ a lot based on the site, right? So some sites are going to be better equipped to deal with these problems with internal staff and resources, and others are going to rely heavily on external resources. So that's probably one of the major factors. I'll just mention a few other ones just to round it out. I think the scope of service. So and these all kind of build on each other. So what's the scope of service included in social needs navigation? We sort of listed how broad that can be. And some of those are more tractable than others in terms of being able to find assistance for individuals. How to screen. We don't really screen patients for eligibility, so to speak, based on, at least for our case management, based on income or other factors. But many who are doing this now are using some sort of screener, just like you would for symptom management for pain, for example, using some sort of screener to determine who is or who will be eligible for some form of navigation. That's a challenge because what's the right screener? What's the right cut point? How to measure quality? How do you know that you're actually providing a quality service to those who need it and will benefit from it? And then the last thing I'll mention is, and this was in your slides as well, Rebecca, this is hard stuff, so how do you train people, the people providing these services and referring to these services, how to communicate effectively with patients in a way that's respectful, that personalizes to their needs, listens to their needs, and then takes appropriate action in a culturally sensitive way, in a way that doesn't scare patients or make them feel like they're going to get substandard care because they're revealing things about their personal life and their financial position that makes them vulnerable. So there's a real skill that's required to be able to do this in a way that builds trust with patients and doesn't, on the other side of it, doesn't undermine trust or build distrust with patients and their caregivers.
And I feel like a lot of this can be addressed through policy initiatives or policy support. I wonder what work is currently being done to accelerate this scaling in the policy space.
That's my cue, Rebecca, as the other Rebecca on the panel. And I'm with the National Patient Advocate Foundation, the advocacy affiliate for Patient Advocate Foundation, where we've really taken a keen eye on how do we truly practice what we preach, or preach what we practice in this case, because PAF has been providing these critical services to help support more personalized care that's directly affecting how people experience access, affordability, and indeed outcomes. And Shanta touched on in her remarks this thinking about how policies have been increasingly shifting cost burden and other elements of access burdens, affordability burdens, even quality burdens on patients. And that's at the expense of good quality and outcomes that we know policy can also equally help rebalance and reorient. So some of the focus that I think so essential is really building off what Aaron talked about and Alan talked about in terms of skilled communication being part of what we do to address people's needs from the get-go based on how they identify them. Typically within the health system, the policies, the procedures, the practices are very focused on medicalizing everything and what's the matter with you. Here with needs navigation, we add the element of what you need most, what's bothering you most, which may be affecting what's the matter with you, so that we also identify what matters to you in terms of access, affordability, and ultimate outcomes. And you featured, Rebecca, this key element of financial burden that's a major stressor for families, particularly those who are already in a limited resource environment. So the opportunity with policy has three main steps, as I might describe it, as scaffolding that we'll hear about in the panel later today as well. The first one is, for lack of a better word, the need to socialize what these services are and the need for them and who benefits. Because there are plenty of stakeholders and allies who don't really realize that the system we now have doesn't account for the social needs that people are experiencing that can create a dire situation. So even naming the problem with specific examples, the data like you presented, and the opportunity to directly influence understanding about social needs navigation as a service that's available to help overcome some of the access and affordability barriers that people are experiencing. Health insurance alone is not enough to get you through. The regulations that are surrounding health insurance isn't enough to get you through. You need that helping hand of guidance that knows what community resources can help you to and through selecting insurance, identifying other benefits and safety net resources that were built for you, but you don't know about them. And it's not something, if you build it, people will come. Policy can help direct people to better, more efficiently use safety net supports and services that already exist. That's a key feature. I think that policy can help with the scaling and the understanding that patients and families need and health systems need as support through this line of service delivery. I think also the standardization that everybody's talking about is a key area for us to focus on with policy, because unless we have core competencies that are understood by all, just like the terms we use, the more we have consistency and core competencies around what social needs navigation services involve, how they help people, how people can be supported to and through the health system experience with their social needs, that takes practice standards that hold people to core competencies of accountability, but also can influence how payment happens. So we know these are steps on the way, socializing, standardizing, and then we can use policy to really influence the scaling so that everyone has reliable, equitable access. And that's going to take reorienting and balancing some of the existing government programs to reflect the need to better recognize the harms of social determinants of health, how you can screen for and address those needs through existing government programs, Medicaid's case management offering already, to expand the aperture of eligibility there to consider social needs navigation as a key service that should be part of that package. There are plenty of government programs that already exist where we can start to test the opportunities for scaling. Community health centers and the work that happens there needs to be part of this family of work, and plenty of other places. Alan talked about the connection between clinical patient navigation and what we know about social needs navigation. A lot of good work can happen to help with that scaling through policy. I think that we're ready and rolling up our sleeves to build the allies to help us support these different strategies.
Thanks, Rebecca. That is such a great insight into what those opportunities for scaling is from a policy perspective. Shanta, do you have thoughts from a community perspective what some of those opportunities may be?
Absolutely. So as we talk about, CDC has this whole this phenomenon or this process or this theme that they call community clinical linkages. And so I think that our path forward to really addressing and responding to these identified social needs won't be achieved unless we begin to force those very tangible and sustainable clinical community partners. And I think those are inclusive of not just organizations like ours, but also those frontline grassroots organizations that are really the bedrock of communities that are working directly with patients who are hearing some of these social needs that individuals are experiencing. And unfortunately, just because of their just sheer infrastructure, not having the capacity to really be able to respond to them. But what if we could truly, as Rebecca pointed out, what if we really could begin to standardize and create a process by which we help to build the capacity of these smaller grassroots organizations to at least assess for these identified social needs and then work with them to create a systemic kind of triage protocol that links to local and national resources to help to respond to those identified social needs. I think, Alan talked about some of the challenges and opportunities. And I think for every question he raised in terms of how do we do this, This is what we have an opportunity to do. We have a great opportunity to ask ourselves this question of, if we can standardize, if we can build a scalable model where we can assess for social needs at every single intersection point of one's healthcare journey, even before they even reach a healthcare system, what if we could systematically assess for, but also have a systematic way to connect individuals with identified needs to resources in a way that it really helps to respond to their very specific need. Social needs is something that we can't do through a equality lens. Social needs has to be done through an equity lens, because it forces us to meet people where they are and at their point of need. The other piece is, by being able to integrate it into systems and standard operating procedures in a standardization that creates an opportunity to make sure that, to the point possible, we minimize bias and we begin to ask these questions around social needs for every single individual who may come into a healthcare environment door. And we're not making assumptions based upon how the person looks that's in front of us, but we have a systematic way to make sure that we're not only addressing their clinical needs, but we have an understanding of their social needs. That's how we get to whole person care.
So much to think about, Shanta. The audience, you guys have heard from 4 of my amazing colleagues, and I want to give you all time to ask some questions. So we have about the next 15 minutes for Q&A. If you can put your questions in the chat, that would be great. And I also want to say that as you guys are typing away, we're going to be diving into these topics a lot deeper over the next few days. So this was a great introduction to what we're going to be doing for the end of this week. Waiting to see if I hear any questions coming in.
Thanks, Rebecca. Yes. While folks think up some more questions, there's a couple here that I can get us started with. So someone wants to know, what are some examples of needs navigation services, and how can this help me and someone like my family?
Erin, I saw you go off mute. I'm throwing that one at you.
Yeah. So it's very unique to the individual's needs, but social needs navigation can be anything from connecting to a local community resource to supporting them, with an application to an insurance product, or even a state Medicaid program, charitable assistance through copay programs or pharmaceutical assistance program, or rent assistance application or utility. They're really encompassing elements of support that can bring a financial or access relief to take away the hindrance that you might be facing, whether it's situational, or we can offer an opportunity for a long-term solution that could alleviate some of the stresses that you might be facing.
Great, thanks, Erin. We have another question about, and I think you all spent a lot of time talking about what Patient Advocate Foundation does for the past 25 years in delivering these services. But what are some other organizations or entities that provide needs navigation? Like, what is the scope of the field, if you will?
Do you want so there's,
or Alan, yeah, Erin, you can probably take that one.
There are so many organizations that provide such a depth of support in needs navigation. Sometimes they're disease specific, state specific, region specific, and I think that, either in your resources in your backyard, whether it be a social worker or, someone in that entity can offer that guidance, and probably just really defining what your needs are and supporting it. We collectively work together to support you and others that have these support needs, and that's why it's such an importance of meeting people where they're at and being that entity. And then if that's not something that's offered by that person, that there's an awareness of where we can triage.
Yeah, I would think about that as, I mean, that's part of the challenge, right? Is there's not a standard way of defining and then sort of you're saying who does this work. There is a lot of this work happening. And as I mentioned a little bit, and others have as well, you do have quite a bit of clinical navigation happening within the health system through nurse navigators and clinical navigators. And there typically are not, they may bleed over into doing social needs navigation on top of the clinical navigation, but that's not their primary purpose. Same thing with financial navigators. There's a lot of health systems and even nonprofits that provide financial navigation, which is usually focused on addressing the medical costs that a patient has, but could bleed over as well into dealing with costs around housing or food or transportation. So there's a lot of blurring of the edges depending upon the scope of service that someone is allowed to take on or that they're willing to take on in their professional capacity, which is often dependent upon how much time they're given to work a case. Our cases average 12 days, correct? There's a 10 to 12 days on average for us to complete a case with the Patient Advocate Foundation. That's a pretty time-intensive body of work. And many places don't have that amount of time to allocate to an individual case. So they may be trying to see what they can do in 30 minutes or an hour, as opposed to 10 to 12 days on average. And then, of course, there's a lot of community-based organizations who do social needs navigation through community health workers, through social workers. They're not in the healthcare system, they're in the community, but oftentimes the people that are coming to them are having an issue that is related to their healthcare or caused by their inability to afford or access healthcare. So it's kind of all over the place. There is a lot of this work happening, but who's doing it, how they're doing it, how they're measuring their success, the types of patients they're serving, the people they're serving, how they're trained, the type of communication, it's varied. And so part of the reason we can't answer your question is because we need that some level of standardization of language, of training, of standards to be able to identify who's doing this work, who's doing it well, how to do it well, et cetera, to be able to more effectively answer that question. But the bottom line, there's a lot of people doing different elements, sort of biting different pieces of this elephant off in different places in different ways. So it's hard to answer that question.
And I'll also add from a community perspective, in terms of some of the social risk and social needs that actually present will vary. They are just as varied as the individuals that comprise those communities. For example, there could be a social risk around transportation in a respective community, but that may not be a specific social need for an individual. They may have a specific social need that's related to food insecurity. And so I think that, so to speak to Alan's point, that gives you the complexity of really how you address social needs, but at the same time, it gives you this opportunity for equity because it keeps us from doing what we sometimes do, which is create a one-size-fits-all response to things. Social needs navigation prevents us from really developing this one-size-fits-all, but it really helps us say, let's really understand the context of the community in which this patient living with XYZ condition has to actually live. And if we're hearing and seeing our community, many issues around food insecurity, but then maybe there's a policy opportunity because we have a major food insecurity social need that's percolating in our respective community. Or maybe we have some major transportation barriers that are percolating that need some kind of local, state, or even national level policy to help us be able to address it. So as we think about social needs navigation, it also gives us the opportunity to say, okay, what are those systemic and policy initiatives that really need to move forward so that these barriers that are erecting, that are in the social space, that are preventing individuals from being able to access and adhere to care, we can begin to form and bring forward these policy solutions to create sustainable change.
Great, thank you, Shanta. And it looks like someone asked a question that you may have partially answered already, but I'll just read it out. that there is data that has come out now that shows patients feel discriminated based on race, disease status, and financial status. And with that in mind, if you could speak any more to the nuance needed by providers who are speaking to patients about social needs so that they feel respected.
So is that directed to me, Nicole, or the entire panel?
I think for you, Shanta, yes.
So I'll start, but I'm actually going to ask my colleagues, both Rebecca and Alan, to jump in, because I think some of this ties back to some of the early work around the roadmap, right, in terms of really creating these conversation pipeline. And that's exactly, whoever posed that question, that's exactly why we're talking about really being able to systemically integrate this into the clinical workflow or standard practices, because we know that bias exists everywhere. And so we have to acknowledge that there is always room for bias. Then we have to ask ourselves, what are those opportunities to mitigate the infusion of bias at whatever entry point as possible? And so that's where the systemic processes of where you say, okay, everyone that comes in the door, we're going to do this assessment around social needs. And based upon what those assessments tell us, we're going to have a protocol that says, if it's a food insecurity situation, we're going to refer to X. If it's a health insurance related challenge, we're going to refer to B, or whatever it is. So until we get to the point to where we really systemically integrate this so that it is a process, we make the process available to everyone, but the resolution is customizable based upon the individual's actual needs.
Yeah, that was a great answer, Shanta. I would sort of pick up on something that you alluded to. It's helpful, I think, to differentiate a little bit between people that are saying they need help and coming to you, not maybe say coming to PAF or going to the social worker or going to an organization saying I need help. That is someone who there's an opportunity to build trust there, or opportunity to build distrust and to make people feel isolated because they're coming to you and saying, I'm vulnerable, I have a problem around these very sensitive issues, and they're asking for help. And there, how you handle that is a lot about listening. You know, it's the same MO to make sure you're not, first of all, not building distrust and not making that person feel like they're somehow substandard, or somehow they're not is their fault. So really there is a science to how to listen to that problem effectively and then engage yourself as an ally with them in dealing with the issue or issues that they've raised. That's challenging in and of itself when someone comes to you. I think I would argue what's even more challenging is when you're trying to find who are people who need this help but may not know it, or may not be thinking to ask for it, or may be embarrassed to ask for it. And there's a stigma associated with it. Now you're starting to proactively probe and ask questions. You're putting a screening tool out there that's asking questions about their financial situation, their housing situation, their food situation, or you're doing that verbally. And that it's important. And this is the challenge, I think, another challenge to scaling. Oftentimes when people come to you for help, they're at a point where there's a lot of things going on, and they're in a pretty deep hole financially and otherwise. So there's a lot of work that needs to be done to try to help them dig out of that, if you even can completely. So it's important to try to reach people earlier and often, rather than waiting until they're in some sort of dire straits and they're actually missing appointments and they're about to lose their home, or they're having utilities shut off. So the challenge to reaching people early is what I said. Now you're broaching the subject. You're trying to identify them, and you're trying to make some assumptions about who they are in their social and economic and other situations to say you're at risk or you may need this help. That is really important work. But I think from a trust factor and from a listening and being respectful and not just building trust, but not building distrust, not making people feel like they're being treated differently. That's a real challenge, I would argue. And we don't have we haven't perfected that yet, but that's where a lot of the science is needed. Is how do you engage earlier and more and proactively in this area rather than later and reactively? Both have the same sort of challenges about how do you communicate. And when we say communicate, it's more about listening effectively, right? As it is, it's as much how you listen as it is how you communicate back and how you engage with individuals. But at the end of the day, the power of it is if someone feels like you're in their corner and you're doing this with them and for them, and their partner in helping them deal with this problem, that goes a long way to building trust. Even if you can't help them, we found with our own work at PAF that even in the cases where we're actually not able to help a patient the way we hoped we could, the way they needed it, the fact that they felt respected, listened to, and heard actually made them feel like the service was worth it, and made them feel better about their situation, even if the outcome wasn't what they achieved. And we hear that same thing in the medical profession as well. If a medical provider really takes the time to listen and respect and personalize the care to the individual, even in the presence of poor health outcomes, that patient will say that they had a good experience with that provider.
And Alan, we have also collected some of that data here at PAF around bias. We know that patients feel biased towards them or discriminated, not just based on kind of what we all think, race, ethnicity, sexuality, gender, but we have patients that reported they feel discriminated against by their provider based on their insurance status, based on their economic situation, based on their diagnosis, and based on a physical or some other personal characteristic. So this bias goes very, very deep. And to your point of bringing this more upstream, we also know from some surveys that we've done that patients don't feel comfortable sharing their economic situation with their provider because they're concerned that they are not going to get the same care as if their doctor or their care team thinks they maybe can't afford something, they're not going to be offered those treatment options. So just our evidence is showing this is a very real problem. And I think you're right. Research, we need to dig into it, right? We need to figure this out.
Great, thank you all for such helpful responses. I think we have just two more quick questions. First, someone is asking, how do I access needs navigation assistance for my patients? So that might be a plug for Patient Advocate Foundation.
Yeah, can I pass that one to Erin?
Yeah, sure. For Patient Advocate Foundation, we have a website, patientadvocate.org, where you can actually go connect to services, and that it will connect you to the case management division and our programs. They have an online application for assistance that you can complete on behalf of someone else, or if you're going to be the point of contact. It's a real efficient way and an easy way to get with them. We also have a dedicated toll-free 800-532-5274. And on our website, you'll also see connection to our copay relief program and financial aid funds, educational content, scholarships, and other areas that we offer.
Thanks, Erin. And I think we just have time for one last question, which is, how can I be involved with the Institute?
All right, well, that is for me to plug, which is great. So we have 2 research-focused breakouts and sessions that are throughout this day and tomorrow. So participating in those is a great way to start. Make sure that you are on the Npaf and PAF mailing list because we will be sending out announcements. And if you are very excited and motivated, you can email me directly and I'm happy to share my contact information because we are going to be looking for stakeholders of all types, patients, caregivers, advocates, providers, policymakers, researchers, to really help partner with us in a lot of those initiatives. So any of those methods, you'll be able to connect with us. And when the website is up and running and ready for an audience, we'll make sure we send that out.
Wonderful. Thank you, Rebecca. And with that, I'm happy to close out the panel and just wanted to give you some instructions for joining the next one, which begins in about 1 minute. So everyone should have received an email with the subject line, "Here's your agenda for Patient Congress." It has all of the links to the Zoom meetings associated with the sessions. So the next session will be 45 minutes. So make sure you select one of those 2, the first being a PAF session on accessing and using educational resources. And then the second option is research advocacy, making person-centered research happen. And after that, we will reconvene at the main stage at 2:15 for our final session of the day. So thank you all for your participation, and I'll see you shortly.
Hi, everyone. Welcome to your first breakout session, our Patient Advocate Foundation's Treasure Chest, accessing and using our educational resources for patients and caregivers. My name is Caitlin Donovan. I am the Senior Director of Public Relations for Patient Advocate Foundation and the National Patient Advocate Foundation. And I am joined here today by two of our most wonderful members of the Patient Advocate Foundation, Amy Giroy and Tracy Hollis. They're here to talk to you about our educational resources for patients and caregivers. But a few little bits of housekeeping first. Just like the first introductory session, you can submit all questions into the Q&A box on the control panel. And we'd really like this to be as interactive of a session as possible. So please, anything that goes into your head that you'd like answered, please type it right there in that Q&A box. There are closed captions available for this session. You can also find that right there down there at the bottom of the screen. And materials will be emailed to you later today. If you're experiencing any technical difficulties, you can email right away at npafevents@npaf.org, where we will be monitoring that inbox, and I promise we will get back to you as quickly as possible. And of course, I'd be remiss if I didn't tell you that you can join us right now on Twitter with #HealthNeedsNav. And I hope to catch you there too. So without further ado, I'd like to turn it over to Amy and Tracy.
Thanks, Katie. That's so great. So I am so excited. I'm going to kind of jump over to our PowerPoint. So I'm Amy and Tracy's going to be kind of co-presenting with me. We are so excited to have you joining us this session. We'll be able to share so much information about our department, not only that, but also how you can access the treasure chest, as they say, of educational resources available to you. So by the time we end our time together, you'll be able to add, I promise you, at least 2 or 3 or 4 valuable tools that you can add to your health education toolbox. So as I said, I'm Amy Giroy. I am the director of the Patient Education and Empowerment Department. My coworker, Tracy Hollis, is our resource specialist, and we'll be co-presenting. We spend our days editing, updating, and creating valuable educational resources for patients, caregivers, and engaged advocates like yourselves, all interested in knowing more about healthcare. So for today, we'll run through a brief introduction for the Patient Advocate Foundation Education Department. And then Tracy, I'll share over with Tracy, and she'll highlight some exciting resources in our library. At the very end, have it be a little bit more interactive, and I would really like to share with you how you can provide your input and real world experiences to help us as we create tailored, effective materials. So a little bit about us. The Patient Education and Empowerment Department creates resources that address a range of topics from medical debt to insurance access and disability benefits. The resources we produce are reflective of real-world experiences that meet the needs of the patients PAF serves. So we have a very proactive strategy to creating resources. Our goal is to mitigate problems before they arise by educating people about healthcare topics. We can empower patients and caregivers using education, which in turn allows them to make better decisions. For example, if we provide a resource to patients that offers guidance on choosing the right health plan, then hopefully they would that would keep them from purchasing a plan that didn't work for them, potentially causing affordability or access issues. Helping people understand healthcare and healthcare processes affords them the ability to make good decisions, steering them away from experiences that really wouldn't help them in the first place. And then, so simply put, healthcare education leads to better choices, which usually means fewer problems. So with that understanding, I'd like to turn it over to Tracy. As the creator of our education resource library, she'll be sharing information about how to access our library of educational materials, and will then highlight several key resources that touch on many of the themes of this year's Patient Congress.
Thank you, Amy, for the introduction. We created the Education Resource Library with the intention of making it easy to navigate through PAF's educational content. Our library of resources encompasses all of our educational content and provides direct connection to our diagnosis-specific tools and materials. You can find one-pagers, booklets, printable materials, interactive trainings, engaging online tools, and more. Before we get into accessing the library and our resources, I did want to highlight the promotional flyer and interactive demo, as they're both great materials to share with others that provide an overview of PAF's educational content. The flyer briefly describes the library, examples of what you might find in it, as well as the direct link to access it. The interactive demo offers an in-depth review of PAF's educational resources and a tour of the library itself. So if you have patients, family, friends, etc., anyone in mind that could benefit from our materials, we encourage you to share these for their review. All of our materials I'm sharing with you today will be available at the end of the day. And of course, they're also available in our library, so you don't need to worry about trying to copy links or writing anything down. The library is set up Netflix style, so content can be easily found. There are a variety of ways to locate the content and navigate the platform to find just what you need. To access the library, simply select the icon labeled Education Resource Library in the Explore Our Resources menu on the homepage. You can also access it directly at patientadvocate.org/education. Now, once you're in the library, you can view content by choosing a topic from the category menu at the top. You can also scroll through each topic and choose materials that way, or you can use the search feature found at the top and bottom of the page. The search feature is free text, so if you are looking for something specific, just type a keyword or two in and content will populate based on the available materials we have on that. Now, once you've chosen a category or conducted a search, you have the capability to then further filter the displayed options. The filters include educational topics, which allows you to choose from pre-populated options, then content type, which allows you to choose the media or format of the content, and a language filter, which allows you to choose English or Spanish. You may use all or some of the filters at once. We have several interactive trainings that are each bundled into a training curriculum. They are all built around the foundation of the power of one. Empowering yourself gives you the knowledge and confidence to advocate for others, and so on. One person can gain valuable information to not only benefit themselves, but also their friends, family, and the larger community. So first up, we have the Advocacy Curriculum, which is an Npaf training series. This series is perfect for anyone who wants to develop their skills in advocacy and bring a greater depth of understanding to the work they do in promoting person-centered care. There are currently 6 active modules with additional ones being released soon, so be on the lookout for those. Next is the Health Insurance Denials and Appeals. Don't take no for an answer. This is a PAF training series. It's a 9-module course that walks you through the process of appealing a health insurance denial to help you get your care paid for by your health plan. The training helps you identify a denial, write an effective appeal letter, and gain valuable skills to pave the way to an easy health insurance approval. The Health Insurance Education Series is an interactive training that's designed to help you make informed decisions when either selecting a health insurance plan or using your health insurance benefits. This series would be great for beginners or those who are interested in kind of a more refresher course. We also have a few that are up and coming. The Navigating the Disability Process is a PAF training series. This disability training will be a step-by-step guide to help you understand how disability is defined, what types of disability coverages are available, applying for disability, what to expect after the application and approval process, appealing a disability denial, and more. We also will have the Medicare Eligibility and Enrollment PAF training series. This training is designed to be a comprehensive but not overwhelming breakdown of what Medicare is, the types of Medicare plans, when you are eligible to enroll based on your unique situation, choosing the best plan, how enrollment works, and more. Our goal with this series is to help guide you through the process of Medicare enrollment and ensure you understand and utilize your Medicare benefits or help your clients to do so. Caregiving can feel overwhelming, juggling so many things at once. You're caring for a loved one, ensuring access to medical and basic needs, navigating insurance, and trying to take care of yourself. If you find yourself in this role, we have some publications that caregivers can benefit from. First would be Reducing Health Insurance Stress as a Caregiver. This is a one-page publication that offers tips to help reduce some of the health insurance related stress you might experience as a caregiver. Moving forward after a diagnosis, this helps patients figure out what's next after receiving a diagnosis. It offers tips on how to become an empowered patient, as well as questions you should ask about your diagnosis, understanding your treatment options, and really feeling good about choosing the best path for you. Although this one's geared towards the patient, a caregiver could certainly benefit if they are attending appointments with their loved ones. The Advocates in Action is a NPAF podcast that's hosted by Ashley Freeman, and she speaks with patients, providers, and caregivers who have found strength in advocating for equitable access to affordable quality healthcare. Specifically, season 2 focuses on help and resources for caregivers, but other seasons include making an impact in rural America, how case management and social workers provide solutions, and the importance of financial and social needs navigation. Navigating health systems can be complex and can often leave you feeling confused. Therefore, we developed both interactive and educational materials to help our patients, caregivers, and advocates learn from a variety of platforms. First, we have the National Financial Resource Directory. This interactive directory identifies national, state, and regional resources to address a broad range of support needs, including access to healthcare or social support services, financial help for cost of living and basic needs, and out-of-pocket health-related expenses. Users can generate a list of programs by selecting search criteria to create the best matches for their unique needs. The search criteria includes simply choosing an age bracket, a residential state, a medical diagnosis, and the assistance type that you're looking for. There are over 33 assistance categories, with some specific to navigating health systems. They include affordable options for care, government services and programs, and legal or advocate services. You can also find other financial and service assistance categories, and I would encourage you to visit the full directory by selecting the National Financial Resource Directory icon, also located on the Explore Our Resources tab on our homepage, or you can also access it directly at patientadvocate.org/financial. Next, we have the Npaf crafted 2021 Marketplace Open Enrollment Step-by-Step Guide. This guide is great because it walks you through the steps on making the best health insurance choice for you, as well as providing fillable worksheets to help you compare plans. Also crafted by Npaf is the 2021 Medicare Open Enrollment Step-by-Step Guide. This guide is a similar style to the Marketplace one, as it also offers steps to enrollment and a fillable section to compare your plan options. Next is how to save money on medical bills. This one can help you navigate health systems from the medical bill perspective. The one-pager offers tips to help identify ways to save on and manage your medical bills. Engaging with insurers, appealing a denial. This is a companion guide to our interactive training on appeals and denials. The 10-page booklet provides a logical approach to the appeals process, as well as practical advice to submit a successful appeal. Paying attention to medical documents can save you money. This describes the importance of making it a habit to review your explanation of benefits against your medical bills to ensure there are no errors. Medical billing errors are pretty common, and it's best to just take a few seconds to verify accuracy then pay more than you actually owe. Lastly is the PAF articles, communicating with insurance and providers. Often navigating health systems include building communication skills, so there's a clear understanding of what is needed as well as actionable steps to accomplish that task. This document is a collection of articles surrounding effective communication tactics when speaking to your provider or insurance company. And that covers resources that you may find interesting. We have many other valuable resources, and I certainly encourage you to visit the Education Resource Library. I'll now turn this back to Amy, who will talk about how we create materials based on patient and user needs.
Thank you, Tracy. That was great. I really hope the resources we shared are helpful and supportive of your healthcare journey. Our main goal is to maintain a library of resources that are timely and relevant. So to be able to do that, we really need to hear from you and what matters most to you. So I'd like to ask you to ponder, what are your real world healthcare experiences? Have you experienced barriers to access or affordability? What information do you need that you don't feel is currently available to you? So this is how you can help. As you think about healthcare topics and what you'd like to learn more about, please remember PAF and our education department. The first way you can help is to go to our education resource library and explore our library using the search box that Tracy chatted about. To access the ERL, you go to the Explore Resources section of the website. When you hover over that section, you'll see an opportunity to click on the ERL icon. And then once inside, you can search for your item by entering in the search box either at the top or on the bottom of the screen. So searching for those topics allows us to monitor activity and notifies us as to what's most important to you. If you don't find what you're looking for, I invite you to scroll to the bottom of the Education Resource Library main page, and you'll click on the Contact Us icon to let us know what information you'd like. At all times also, you can email us directly at education@patientadvocate.org. We'd love to know what's important to you and others using our resources. So number one, so not only we can promote those resources so that you see them right when you open up the website, but then also it also helps us know what resources may be missing and what we need to create to better help in the creation of a robust library. This is really exciting. So the newest item I'd like to highlight is something we're calling the Spotlight. On a monthly basis, we compile those questions that our case managers get. Not only that, we also put in the queue those keywords that we talked about that were searched by users like you. And then we also tap in, I chat with Katie quite a bit about what the reporters are asking on a monthly basis. And then once we have that cumulative picture of what's important to people, the department, we've started putting together one publication, a one-pager that we're calling the Spotlight, where we really drill down on one recurring theme that's important on a timely basis, and then 3 associated questions that target that need. And always at the end of those, we direct individuals to specific resources within the library that touch on those topics. So what you see on the screen right now is our debut one pager. Came out in October 21, and it focuses on how you can save money. Excuse me. Again, it wouldn't be a patient congress if we didn't have little technical difficulties. So thank you. I hope this was really helpful. As a department, we really are here to help you in identifying whatever resources would be most helpful to you. So at this time, if you'd like to reach us directly, our contact information is right on the screen. And I would like to pass it over to Katie to maybe help answer any questions that have popped up or address some topics that we maybe didn't discuss that you'd like more information about.
Thank you, Amy. Thank you, Tracy. So I find all of the resources here so helpful. And as I've been with the organization now almost 10 years, over time, I've gone through a lot of them because my secret goal in life is to be an impromptu case manager. So I was wondering, one of the biggest questions we receive from patients and that we get asked about publicly is about how to save money on healthcare. So if you had to recommend one resource to people who are either looking for themselves or looking for someone they're caring for, which one would it be?
I have my favorite one. Tracy, do you want to jump in first or would you like me to? I think you're on mute.
Oh, Tracy, you're muted.
Sorry. You can go first, Amy. I'm interested to hear what your favorite is.
My favorite is a very basic one, and it's kind of make sure you have health insurance. That's just almost seems too obvious of an answer right now, but we're coming into open enrollment, and it really is important that you take care of yourself by making sure you have the appropriate coverage. You never know what's going to happen. You might be healthy these days, but in the future, that's just like paramount in terms of priority number one.
Okay, and if I had to pick one of our resources specifically that could kind of tackle that, I actually would recommend paying attention to medical documents can save you money. I think sometimes people may tend to just receive a bill and either ignore it or pay it, and just they don't think to look at the documents that they receive from their insurance to kind of just compare and make sure that there were no errors from the biller's side or provider side. And sometimes you may not even realize you paid something that you really shouldn't have. And once you identify that, it's just a simple matter of contacting the billing office of the providers and letting them know that's not what my insurance said. And sometimes it could really save you a lot. So that would actually be one of my top picks out of our library.
One of the things I remember that was astounding to me when I first started talking to everyone was this refrain that like at least half of medical bills that we see have mistakes in them. And that the most common one was providers directly billing patients instead of submitting to insurance. So my very nerdy anecdote is that in my last pregnancy, I kept track of all my bills and how many of them had mistakes. And it wound up being exactly half of them. And the most common one was the bill going straight to me instead of to insurance. And it wound up, I think, my total out-of-pocket cost for that pregnancy was around $2,000, but it would have been an additional $750 if I hadn't found those mistakes. And it was so easy to do just because of that advice you guys gave me, which was just check your EOB, make sure you get that before you get your bill, make sure the amounts line up. It's really helpful and really simple. One of the questions also that we have that came in was, though, for people who are a little bit more advanced, is there any type of modules they can take or something, like, especially if they're working in an office, that might help them through like appeals, denials, and mistakes maybe?
So exciting. So yes, so exciting. So this is one of the things, this goes back to our interactive trainings. The appeals and denials topic specifically is really fun because we have an interactive training series that people can take. It's really benefited case managers, financial navigators, and then just anybody interested in helping not only themselves, but their friends, family, community members. So there's that web interactive training series, but then another one of the resources that we discussed was the actual publication that we have that specifically targets how you appeal a health insurance denial. So you actually then could get a printed publication through our mailroom. There's an opportunity on our website to order printed publications. So those can actually just free of charge, whatever you would like. If we have it printed in our mailroom, we can send it as many copies as you'd like.
People love those. I've done sessions here just at my local library for people, and they grab all of them. It's great. It's a great resource. So any of you advocates out there who are looking to just do a little quick good, that's a really good idea for how to get started there. What about, I know there's some like disease specific or condition specific resources that we have. Can we talk about those a little bit?
Ooh. So the way that our education resource library is set up, as Tracy mentioned, it's very, thematically, it looks very much like Netflix. So you'll open up the main menu, and as you scroll down, there are different categories. Many of the categories are disease specific. So we have a hefty amount of resources in the migraine field, as well as our cardiovascular resources, breast cancer, to name a few. And within those, I know our breast cancer resource directory is incredibly attractive. Tracy, you keep track on the different publications that are specifically targeted. Do we have any disease specific ones that consistently bubble to the top?
Well, so what you could do to find the disease specific ones, if you're in the library and you choose, for example, you choose the migraine category, it will take you directly to our migraine page on the website. And on that page, you can visually see all of the publications that are available, and you can download them straight from one screen. They all surround topics that we have went over today that are very important. It's just geared towards that diagnosis. It's the same layout for the cardiovascular community and the breast cancer community. So if you visit any of those pages, you can actually visually see each publication that we have to offer.
The Migraine Matters one, I think, is very special to me because when I was first getting hospitalized with cluster headaches 15 years ago now, nothing like that was around. And now I look at it and it feel like it preemptively answered so many of the questions I have. These resources are really special. And I know I've spoken as a patient on panels talking about Migraine Matters. And every single time when they get to the resource part of the program, there's this awkward moment when we realize all the panelists are talking about Migraine Matters instead of any other resource, because it's the best one out there. It's so comprehensive, and it has the added bonus of linking people to case management services, which are, just the icing on the cake when it comes to all of this education and resources.
Yes, it also has the cardiovascular and the Migraine Matters also have the interactive tool, which is really neat because it can connect users to a variety of resources. It has a lot of different topics, visuals, printables, up-to-date articles, and our team also manages both of those tools, and you can also connect to those by choosing that diagnosis specific area in the library.
And speaking of resources that are one resource that's full of other resources, the obvious one is the National Financial Resource Directory, which you guys spoke a little bit about, but you failed to brag a little bit about it too, because it's now the award-winning National Financial Resource Directory, right? What was the award that won?
That was, Amy, refresh my memory of the name of it.
The Digital Health Awards.
The Digital Health Awards, that's it.
Yeah. And that one's great because I remember we would go up to the Hill and talk to new members in the House of Representatives. And every single time I would go and sit and talk to the case managers they have in their offices, and their eyes would get big when they saw this resource because it was everything that they needed for their constituents, but nobody else has this. It's really unique. And it's just very fundamental in this is what I need, this is where I am, and here's the resource.
Yes, it is one of our most utilized resources in most cases. Usually over 30,000 searches conducted each year at a minimum, and we keep that up to date. We add resources every day, every week. We try to keep them up for accuracy, and we really try to make it so that when users use that tool, they can really connect to a viable list of resources that would seem to be a benefit to them, to at least connect to. So I certainly encourage users to
I had no idea it was
try out the
30,000.
tool.
That's so many. And now there's also the COVID specific directory too. Can we talk about that a little bit?
Yes, so the COVID specific directory is actually available on our COVID care webpage. That's patientadvocate.org/COVID care. You can actually connect to a variety of services from the page itself, case management services, if there are any kind of educational videos available, as well as the Resource Center. The Resource Center is also a database of resources broken down into categories or topics, populations, and they really are focused on just different areas of dealing with COVID and everything that came with it. You can find resources, like practical resources, such as if there's any kind of help for financial needs or grants, co-pays, things like that. Or you can also find other kind of resources that are unique, maybe how to set up a home space if your child is doing virtual learning, or resources for caregivers and caregiving and legislation. All kinds of resources are in that, and it's also just free to search and free to use, and you can just get your list. It'll connect you directly to whatever you're interested in through the link listed with the resource, and that is also pretty heavily utilized on our website.
Tracy, you just pointed out something that I think I really want to make explicit, which is that the point of all of this, kind of the Greater Patient Congress, is to talk about how often patients think that they can only ask about direct medical issues when they come to PAF or when they are talking to their doctors. But we don't compartmentalize our life the way we compartmentalize maybe a paper we write. So if we're having trouble with transportation, that means we're also having trouble with our healthcare. If we're having trouble with getting our disability payments, that means we're probably also having trouble with our healthcare. And so making the explicit point that these resources are available, and they're available for the entire course of your life, I think is really critical, because I've even seen childcare resources right in the resource directory. So the thought that goes into these directories and to these resources that you guys put together is just really incredible on both like the micro and macro levels. So I just really wanted to point that out to everyone watching. We got a question that came in. I think we addressed it a little bit earlier, but maybe we should also be more explicit about this. They're two separate questions, but I'll combine them. Are these resources, can people order them when they're ordering them? Can both patients and can providers order them in bulk?
Yes, yes.
Good.
Yes, yes.
And I can personally testify that I know that it's a quick turnaround. It's really impressive. So that's available for everyone.
Both are. And so when you go into on the website and on the drop down for Explore Our Resources, there are two larger buttons that'll allow you to tailor your search. So it gives you a list of what resources we have available in print and how you can get those. If you don't, also just worth noting, if you don't see what you're looking for in the printed section, that just means that they aren't in our mailroom ready to go. So number one, we would like to know if you'd like those printed and available. We kind of try to read your mind a little bit, but we're going to fall short sometimes. So if we know that you'd like something professionally printed and in our mailroom, that's important to know. But number two, if you need it at the ready and it isn't available to be sent out, everything can be downloaded for you to be able to print up yourself at home. It might not be as pretty, but you would have the information. So yeah, those are just those little buttons.
That's a really good point. And I think there's probably someone out there watching thinking like, I don't think I can hand these out. Maybe I don't have the expertise. I'm not a provider. And I want to point out to you that you know more than you think. And I don't want to like tell anyone that they're an expert if they're not, but if you need a little bit of encouragement, watch some of those early videos, some of those, the ones that Amy and Tracy were talking about earlier. Check them out, get your feet a little bit wet, and then just hand out these resources, encourage other people to do the same, to go and explore the website and explore the resources, because sometimes all someone needs is a little bit of encouragement and almost sometimes permission that they can push back maybe on the financial services that they're not getting, or that they can talk to their provider a little bit more directly. So permission granted, go and educate yourself and spread a little bit of that knowledge around.
So if you need to kind of piggyback off of what Katie's saying, if you need a springboard, if you're really just starting, the health insurance literacy webinars, those interactive trainings really offer a beautiful, if you're just dipping your toe into it, really want to get to know the whole landscape, that's a nice starter point. And many of the topics that we discuss in those different modules are just a starting point. So we may reference, your explanation of benefits, or, oh my gosh, what happened? What's this in-network, out-of-network thing? So we kind of introduce topics in that webinar series that is supplemented with companion printed materials, but then we may dive deeper in other webinars later on down the line. So that's just a nice way to kind of get started.
And a plug for health insurance literacy is that I know a new study just came out that talks about how much money people lose and how much access people to the proper care they lose just because they don't understand some of these terms. And I think it's a really important point that the amount that you can help yourself by just learning some of these terms and being able to identify them out in the wild can be really helpful for you or for whoever you're caring for, your family, your neighbor, whoever it is. Just these little baby steps can go a long, long way.
Mm-hmm.
And check to see if we have more questions. So when we talk about these resources, we talked about for people who are looking for financial terms, is there anything that you think maybe transportation related or something that's not directly related to insurance that you think is a good resource that we should spotlight as we wind down?
Of our resources that we have available? One that keeps bubbling up, I know we've kind of chatted about the things that have been pressing and bubbling up on a present current time. Concerns around paying for prescription medication keeps bubbling up quite a bit. So that's happened a lot this month, but even the last, throughout the entire summer. So Tracy, we must have pulled one of those. I want to get the title right.
Of
Saving
what?
on your the resource, the publication that we chatted about that addressed that topic.
That address prescriptions?
Yeah.
You put me on the
While
spot.
she's looking, I'll jump in there and say that I know that there's a lot of good resources here because
Several.
there's a very high need for information on this topic. And what's great about PAF's resources is that they always include a lot of just tips and also outside resources that you can use. So anything from making sure that you have that healthcare audit with your pharmacist or your primary care physician to make sure you can't lower your overall costs. Or are we still on? Or using sites like GoodRx or checking to see if switching to delivery services might lower your cost. These are all different ways you can go about lowering your costs that are mentioned in some of these resources.
Yep.
Okay, well, I think that we've wound down this. I can't believe how fast this session went. Thank you everyone for joining us. I want to reiterate to everyone that you can find all the resources that Amy and Tracy discussed at patientadvocate.org, along with a few at npaf.org, like the health insurance guides and marketplace guides. We are going to join everyone in 15 minutes back on the main stage, and I look forward to seeing you there. Thank you very much, everyone.
everyone, and welcome back to day one of Patient Congress. This is our third session for the day. Just wanted to welcome everyone back. Hope you had a quick bite to eat during the break. And without further ado, we will go ahead and get started. I'll pass it off to my colleague here, Becky Ship. With first, just a reminder for folks, if you would like to share where you're from, your name, just please enter that into the chat so we can see where you're calling from. Here are just some housekeeping reminders for you all to see. Again, closed captions are available for this session, but if you have any issues accessing that or just technical difficulties in general, please email npafevents@npaf.org. And then if you're on social media and would like to chime in with your thoughts, feel free. You can follow us. Our handles for Twitter and Facebook are at the bottom of the screen here, and we're using the hashtag #HealthNeedsNav for health needs navigation. So, without further ado, I'll introduce my colleague Becky Ship, who will take us away.
Yes, good afternoon, everybody. Welcome to our final session today, Policy Strategies to Advance Needs Navigation. I'm Becky Ship. I'm a policy advisor at National Patient Advocate Foundation and a former Congressional Hill staffer working for many years on the Senate Finance Committee. The purpose of our session today is to review the policy landscape from several different vantage points. We're very fortunate to have three fabulous speakers who will speak to various aspects, clarifying the need and the opportunities to advance social needs navigation work, meaning moving forward. I'll do a brief introduction of our speakers. We'll let them take the floor in the order that they'll be introduced. And then we'll have hopefully some time for some Q&A and thoughtful discussion. We're very fortunate today to have Sarah Hudson DeSalle, who manages the medical assistance programs at Wexner Medical Center and the James Cancer Hospital in Ohio. She provides assistance for patients in and out of care who cannot afford their medication. She also serves on the board of the Charitable Pharmacy of Central Ohio and is a key contributor to the Financial Advocacy Network of the Association of Community Cancer Centers. She will give an overview of who is affected by the need for financial navigation services and why and how those services should be expanded. We're also joined by Stuart Portman, who is a longtime top policy aide and advisor to the Senate Finance Committee. Stuart has served under two chairmen and now the ranking member of the Senate Finance Committee. As some of you may know, the Finance Committee has jurisdiction over all of the health entitlement programs, and Stuart's been a part of many critical health legislation going back nearly a decade. He's going to talk about the federal legislative landscape and the opportunities to use the legislative process to address the need for financial and social needs navigation services. We'll be joined as well by Jamie Stokely. I think we've got a few technical issues getting Jamie with us, but she should be along shortly. She is the founder and CEO of the Helping Harvest Foundation, a nonprofit serving the disabled and aging community. She's a critical volunteer for National Patient Advocate, and she will speak to the view from the ground and the lived experience that she has borne witness to. So we'll start with Sarah, then move to Stuart. Hopefully we'll be joined by Jamie, and then we'll have time for Q&A and discussion. So Sarah, I'll turn it over to you.
Thanks so much, Becky, and thanks for having me today. And welcome everyone to our third session. I really like to just kind of give you a little bit of background. Some of you may or may not be familiar with financial toxicity and how that impacts really patient care and cancer care specifically. I've been doing this work for a really long time and have seen a lot of various patient stories come across. And I think really background, like when we start to talk about financial toxicity,
It is a term typically that we use that has, it's kind of gained some traction over the last decade, but it describes where a patient they can't afford the cost of their medical care. And it's not necessarily not having insurance. It may not be having insurance, or it may not be having enough insurance. And that leads to kind of health and social discrepancies that folks would, end up in, that lead to like debt, bankruptcy, that things that basically, end up having poor health and then poor financial outcomes. We know that distress is higher in our cancer population. Typically, it follows when folks have high out-of-pocket spending relative to like their income and assets. They lose work. I mean, you think about a patient going through the cancer treatment, they're not going to be working as much. They will have a significant household debt. There's distress that come with those delays of, lots of times you end up seeing delays of treatment, limited patient adherence, because folks are going to say, well, I can't afford this, so I'm not going to follow what I need to do because of the cost of the care is too high. And then that erodes then the effectiveness of the other treatments that it's designed and what it's been able to do. And I think we see that from our providers. They're concerned about our patients' their cost burdens, and especially with new and novel agents that are coming out. The price tag is really high on some of these medications. And the new generation of these folks, but if we don't have we can't adhere to those treatments, that we kind of come through, it comes through of basically a not great outcome. Those high costs of those cancer agents, I think lots of times we see are compounded by really the growing bridge of inequities that have come along with insurance design. Kind of a little bit of statistics. In between 1999 and 2011, we saw premiums and deductibles increase by 170%. For patients that had to spend more out, but their incomes only increased by 50%. So, really you end up with folks that are upside down and they're unable to, really afford that. So then we start to see those coping mechanisms kind of come into play for patients. So they may, follow, they're borrowing monies from family, friends, looking towards organizations to try to help them for goods and services, depleting their savings there, and looking towards assistance from pharma grants, sale of those assets. And so it's hard to kind of put yourself in those shoes of how would you handle that? And I think, and I'll put on my little advocate hat here for a couple minutes, as far as with ACCC has put together the Financial Advocacy Network. And it basically is a network that our goal mainly is to take the knowledge of how you help patients really navigate these systems and these services, and figuring out ways and solutions for these patients to kind of go forward. And really, I think, our goal in the healthcare system, at least, would be able to deliver patient access to treatment that improves quality of life without without bankrupting an individual, without bankrupting an individual and really depleting their ability to, have those needs, those lifelong needs, so you don't want to forego food, shelter, safety, and then also making sure that we don't also decrease their disparities in health and wealth. And so I think that we have opportunities that are here, for insurance optimization, that we would see more of a proportionate means for out-of-pocket expenses for needed treatments, whether they be for infused treatments that happen in the clinic or oral treatments that happen at home, and helping to make those really more proportionate, and not so having such a mismatch of what the insurance population would be today. So with that, I'm going to kind of hand this over to Stuart and see if some of the things that he's able to kind of share with us.
Thank you, Sarah, and thank you everyone else for being with us today. It's great for me to join you. And as Becky said in the introduction, it's a pleasure to be here from the Senate Finance Committee, from the minority staff. I think there's a lot of really amazing work being done right now as it relates to how increasing access and changing the sort of paradigm of, if you're going to have access to care, that's going to now require, in our increasingly complex system, a little assistance, a little navigation. And that concept has sort of permeated a lot of aspects of federal health policy. We've seen it more and more, and I'll give a few examples. But I would say from the outset that the discussions that we've had have, here on Capitol Hill, have gotten more complex as we've discussed things like care coordination and case management in particular. We can pick a specific use case. We can pick something related to, talking to an insurance company. You can talk to a provider or provider group working with a hospital. It doesn't matter who the person, a patient, is working with. There's always a level of outreach where the expectations today for care, especially in my area, which is the world of Medicaid and the Children's Health Insurance Program, there's an expectation that care coordination and some level of case management is the norm. It's not just a system of fee-for-service healthcare where you go somewhere, get billed, and that rinse and repeat. There is an understanding now that if the focus is the health of the person, that it's going to require some work to make sure that all the follow-up is taken care of. Any additional, prescription review is taken care of. If there's anything related to a step therapy or a prior authorization for getting a type of treatment, that those things are taken care of as well. And it's a lot for people to take on. And so expectations, we've noticed, are starting to shift. And that's why it's changed a lot of how we address issues in the health policy space more broadly. And you could see this with children and the rise of additional health homes for kids and the use of the EPSDT benefit more broadly, as there's increasingly more guidance on care coordination being provided on that issue in particular. So there's a number of areas here where I think we're starting to see Congress engage a bit more. One in particular, just to give you a sense of what current discussions are on Capitol Hill, is in the Senate Finance Committee, there's a bipartisan request for information related to behavioral health. And so we're doing a deep dive into the world of behavioral health and the broader needs really in 5 buckets. And one in particular that I note is specific to integration of care and access. When you think about what that means in practice, and we joke internally because there's a lot of support for integration in the mental health space. But when you talk about what that means for mental health and physical health, there's no clear-cut definition. And a lot of really smart people have put forward concepts and constructs around it without having to fully define it. And so we joke internally that we get to take a bite at that apple and come up with a way to discuss integrated care. What does it mean across a full continuum of care? What does it mean about co-location of services? What does it mean when you're dealing with adults versus when you're dealing with children? How do you discuss all of those pieces? All of those pieces only work if there is a level of assistance and engagement to make sure that the various services that are intended to improve outcomes and reduce system costs actually happen. And that follow through is going to, that's a very real part of the conversation today. And so I thought that might be of interest to you more broadly. I think that there's a lot that I could dive into in the weeds, and I'm sure that in the questions and from Becky and others participating, there'll be an opportunity to do so. But I may toss back to Becky and see if there's other areas that Sarah and I can speak to, and hopefully Jamie joins soon.
Yes, thank you, Stuart. I understand we are still waiting on Jamie. So as part of the refrain for these strange times, we'll just kind of be flexible and engage. And when Jamie arrives, we will hear from you. Just a point of clarification, Stuart, for us Medicaid and CHIP geeks, we know what EPSDT is. You referred to it in your talk, perhaps for the good of the order, for folks that aren't nerds like us, maybe just talk a little bit when you refer to the EPSDT benefit and the expectations around care coordination, maybe just a little table setting what you refer to, what you meant by that.
Sure, happy to. And I try to tell myself not to use acronyms, but there's so many. I feel like I fail frequently at that job. So EPSDT stands for Early and Periodic Screening, Detection,
Diagnosis
and Treatment. And so, wow. So yes, it is a benefit package for children, for those under 21. And it is pretty comprehensive in its scope, and is frequently, while discussed, well, it was developed in the past, and the benefit itself hasn't been discussed as much recently. How we are seeing, different types of care from specialists and primary care, how we're seeing additional services as Medicaid in particular has taken on a larger role within the social determinant space, and you're providing more touch points to non-health components of a person's well-being. A lot of those sort of touch points require case management, and a lot of those types of interactions can still be covered under the benefit that is under EPSDT. And so that's why additional guidance is helpful here, because as the bigger push for more different types of service delivery and additional non-medical services are incorporated, it's going to take on additional types of navigating.
Thank you. I myself, I always have to stomp my foot on my other foot to remind myself not to speak in acronyms. Nicole, do you have access to the general chat? I'd like to open it up while we wait for Jamie for questions from the group for either Stuart or Sarah. Are there any of those?
Yeah, looks like, let me see. We do have a question from someone asking, do I need to be a nurse practitioner or case manager or any specific type of service provider to be reimbursed for navigation services in the community?
That's probably, Sarah, do you feel like you can address that, or is that?
So at this time, as an APP would be recognized as a provider in our current reimbursement structure. And as far as for services that would be, that would be provided in that day-to-day, care could be reimbursed. Now, with a social worker, typically it may or may not be, reimbursable, but for a financial advocate, it is at this point, there is not like a recognized, position or, standing to have reimbursable services for the work that they do. And that work, lots of times, and I'll put that hat on just a little bit, they do a lot of case coordination, whether it be through insurance, financial distress screening, prior authorizations, insurance education and navigation for folks, financial assistance, whether it be through grants or patient assistance programs. And those are things that it is at this point is not recognized in a true provider status. It could be reimbursable along with services in more of a nurse practitioner and an APP role. And I see Jamie has been able to join. Becky, do you want to?
Excellent. Jamie, we gave a brief introduction earlier while you were experiencing technical difficulties. They know that you're the founder and CEO of Helping Harvest Foundation, a nonprofit dedicated to advocating for disabled and aging communities, that you're one of our volunteers at Npaf, and you're going to speak for the view from the ground on the need for social navigators and describe your lived experience with your clients. So we will turn it over to you. And then for the good of the order, we will pick up again on the Q&A once Jamie is finished with her presentation.
Hey everyone, I'm happy to be here. Again, my name is Jamie Stokely. I'm the owner of Helping Harvest Foundation, a nonprofit organization that advocates for the disabled and aging community, no matter the financial status that they have. As owner of Helping Hands of the Cape Fear, which is a home healthcare agency, alongside of Helping Harvest, we noticed that within home care and in any healthcare, we noticed that the community were suffering and struggling with affording the medical needs that they needed at home. So Helping Harvest was founded through the work that we were doing in the community. We realized that the disabled and disadvantaged communities in the Cape Fear region could not afford some of those non-medical services that were vital for their quality of life. We decided to take that extra step and provide the resources that they needed to make sure that they had the quality of care at home. Medicaid, and Medicare do not cover some of the non-medical services that some of these families and community members needed. And so without them having the financial and social ability, they were a lack. So we realized that there were a gap. And we were passionate enough to go out into these communities and, surveys and do statistical analysis and find out that there are so many families, especially in, in my community in North Carolina, here in the Cape Fear, that are suffering from these needs. At Helping Harvest, no matter your financial status, we still try to link the families to the resources that they need to make sure that they have great quality health care. There are resources out there. We've partnered with Npaf resources, PAF resources. Volunteering with them has helped us find the resources that our community needs back here on the coast. I say there is a great need for home care and healthcare resources, great need for financial ability. The families that can't afford these services are suffering, and they are struggling with taking care of themselves and their loved ones. And that's our mission and our vision here at Helping Harvest, to make sure that we navigate systems, help them navigate these healthcare systems, help them find the resources and fill the gaps that they need to make sure they have the quality of care. We believe that, everyone deserves care, no matter their financial situation. But if we had those resources in place, if we had the finances in place, because we can't do it all for free. I mean, we have the mission and the vision to try to serve as much as the community as we can, but we can't do it all. Our waiting list is extenuous because there is a need and there's a lack of financial resources in our community as well. And that's what we do at Helping Harvest. We continue to navigate these social and financial distresses to see how we can help the community and build and make a better impact in the financial and social need that the communities have.
I'm on mute. Thank you so much, Jamie. Really appreciate that. And thank you for your grace under pressure. These technological challenges are not for the faint of heart. Nicole, do we have any questions queued up in the chat for either Jamie, Sarah, or Stuart?
Yeah, it looks like we do have a Medicaid question. So let's see, perhaps this is for you, Stuart, but anyone can chime in. So Medicaid also affects people with disabilities at any age. Needs navigation for comorbid and critical conditions may play a role, but how can this be addressed within the context of Medicaid?
That's a fantastic question. I think it's one that we know is constantly being discussed in states. We know it's being lived on the ground, and it is constantly a source of conversation in Capitol Hill as well, in large part because individuals with disabilities make up a group in the Medicaid program that will be high utilizers of services within Medicaid. So trying to make sure that people get the services that they need and that they are the most appropriate services, but especially when it comes to individuals with disabilities, also not just the most appropriate, but also the preferred from the individual. That has become an increasingly important component, and trying to make sure that the person's voice is a part of the conversation is something that I think we've been hearing more and more and more. Now, when it comes to specific policy pieces, there are, I think there's a mixed bag here. I don't know that there's a specific policy currently in the works that can say there is increased access to sort of that type of service, but there's also no ban on it. So it becomes more of a allowable use that states can really lead the charge, because the federal government doesn't prohibit it, but it's very much so allowable under the various waiver programs and base programs, especially within home and community-based services, and the waivers associated with home and community-based services as a form of long-term care. So there is an allowance by nature of there not being a prohibition, but that doesn't mean that there isn't more that can be done. And you all are probably experts in providing examples of how proactive support can do a lot more than tacit allowance. So I think that there's a lot that we could learn from you, and I would be happy to do so.
Thank you, Stuart. We do have another question from one of our volunteers. This one is actually for Jamie. She wants to know, are you helping patients connect with dedicated hospice care? Her mom couldn't afford the daily room and board costs to stay at the hospice home with 24-hour care, and it wasn't covered under Medicare. So, at your nonprofit, are you helping to connect patients with this type of hospice care?
Well, we help connect you to the resources. So what we would do was we would reach out into the communities and reach out to the different networks to try to find some financial assistance to make sure that the client would be able to have that extended stay, being that they couldn't afford it. So we absolutely would try our hardest to find those resources, fill those gaps, and we're in the process now of trying to have that type of funding available so that when those clients do have that issue, we will have the funding on staff to provide it to the family that needs it, because we see that need as well.
Got it. Thank you, Jamie. And maybe Sarah, to build on that, what's an example of some of the types of the ways that you connect patients in your area to whether it be hospice or different types of supportive services?
Yeah, thanks so much. I think that, building bridges and connecting patients is kind of really a paramount of what like a financial advocate, or even in our practice of helping those patients figure out what's the bridge into to that area. And so, it does take a village. So whether it's, in my space, I deal in drugs a lot. So, we have resources such as, our pharmaceutical partners that have assistance program, nonprofit organizations that help with, co-payments, co-insurance, COBRA payments, transportation, lodging for those patients. Lots of times some of these expenses that are not typically covered by insurance will start to add up in those family care. And so many times if a hospice or an inpatient hospice would not be covered, or an outpatient, it covers very little. How do you bridge those gaps? And lots of times it is getting linked into various resources. It could be national grants, it could be, local organizations that do help that, and helping those folks apply. And really that is where, many times of looking for those helpers in your system. So whether, it is an organized financial advocate in your care, in the practice that is occurring, or volunteers, such as PNAF folks, it's one of the things that it will keep going. And I think for, whether it's a small center or a large center, of having those repositories of resources is very beneficial for patients, their caregivers, and even to the providers, of making sure that folks can get the needs that are necessary.
So thank you. So I've got a question for the three of you from your particular vantage point. So I'd be interested in hearing Sarah, Stuart, and Jamie address this issue. So as I understand it, financial and social needs navigation seek to provide patient-centered care. But often we hear a variety of what is meant by patient-centered care. Can you all each speak to, from your particular vantage point, how you would define patient-centered care and how that can have implications for the policymaking process? Sarah, we'll hear first from you, and then Stuart and Jamie.
I'm happy to kick that off. So thanks so much. And I think patient-centered care, as far as how I see that, really in care, I've been practicing pharmacy for a bit, but we've seen the toolbox of how we practice, and the therapies that we practice really expand and grow, in so much that, the opportunities for patients that, 10 years ago may not have lived 6 months, now are living, and increasing their quality of life, having, being able to hit those milestones, whether it's graduation or, a wedding of a loved one, or maybe into remission, that they are moving forward. And really our toolbox for each one of those patients in that social and financial needs navigation also needs to continue to grow, and having, I think, really individualized conversations with patients when they come into treatment. They have those conversations around what the expectations are, what are their fears, what are the things that, that they're concerned about and treating. And then the centers where they're being treated have a responsibility to link those folks up with, resources that are available to them, and then making sure that, our insurance providers know, these are the most recent up-to-date treatments that you're going to have your patients getting. And so it does become more of a secular pattern, that, one begets the other. And I think it's how we start to, chip away at kind of that financial toxicity, in my opinion, and start to move that marker in the landscape where we're at today.
Excellent. Thank you.
Thanks.
Stuart, you want to take a shot?
Sure. And I think it's a great question. And I think it's a constant policy struggle, right? Because you want everyone to feel like they are getting the care that they want, that when we're talking about patient-centered care, obviously it means both patient input and preferences. And yet when you have a policy system, it is intended to be broad-based. So it's hard to actually put together a broad-based system that takes everyone's personal thoughts and preferences and concerns into consideration. But there's a way to blend it. And we've seen that in a lot of examples around the country. I think when I personally think about what I've seen as a success in this area, it's when you have someone who is prescribed some course of treatment, and if they raise an objection for some reason or another, that's because of a personal experience, something that happened to a family member, and whether or not a provider is willing to work with them to find a course of treatment that can achieve a similar or the same outcome, while also making sure they're more comfortable. or if someone is opposed to something in the drug space in a step therapy where you have, or a fail first policy. How do you work with an insurance plan, and how do you work with a provider to make sure that the person gets what they need in the most effective and expeditious way? So a lot of the times there are utilization management controls that are put forward solely for the cost-based efforts because there have been issues in the past. And I think that there's a real conversation now on how to make sure that you don't have so many barriers that you're preventing effective care from being in place. And the way we get there is by having more input from the patient themselves.
Thank you, Stuart. Jamie, let's hear from you.
Within home care and advocacy, we view person-centered care as specialized care. We try to use simplified care planning to provide like specific care needs. Sometimes policy conflicts personal-centered care because we're not allowed to do certain things. Within the home care sector, we try to make sure that that person has the needs that they desire to have, whether it's end of life, whether it's long-term, short-term, or rehabilitation. We believe that those small things count. Sometimes we have certain stipulations within policy that exclude certain needs that the client wants. So we're not able to provide that. So we try to implement it by implementing simplified care planning. That meaning that we will focus specifically on the person that we're providing the care for. With that being said, we see personal-centered care as just making sure that we provide the needs that that client needs.
Excellent. Thank you so much. Stuart, I'm going to put you on the spot again. Many of the folks in our audience today here in Patient Congress have real life stories illustrating the need for broader access to financial and social needs navigation. Can you just talk through, from your vantage point, how best to communicate these stories with members of Congress, and any tips you have on communicating with folks like yourself and members on the Hill?
Sure. I know that making sure that there is access to members is highly important. I think that if there's I would say that while one-off letters are read, when you are coordinated, particularly if it's through a group like Npaf, and you have the ability to have a cohesive discussion with staff, you can sort of work with those aggregators, if you will, of advocates to make sure that you and a few others from a representative's district, or you and a few others from a senator's state have the ability to relay those verbally. I've read many compelling things, but when I have the ability to have a conversation face-to-face or virtually face-to-face, it will always be more compelling, interesting, and I will take a deeper interest. There's a lot of staff that are being pulled in a lot of different directions, but when you actually hear the human impact of when things work well, and also when things don't work well, and how if this were available, it would have changed an outcome. Those are very honest discussions that people have to pause, they have to listen, and they have to take it in, and it can change the way that they think about policy. I think that when it comes to getting access, if every one of you were to send your own letter in, it'll get read, but it won't have the same effect as if you work through a group of like-minded individuals so that you can relay that information as a group, because you're also going to have a more effective way of getting a meeting. It's not that meetings are prohibited from constituents, but you'll be able to make you'll have a better way to make that sort of a change, because you'll hear multiple perspectives at the same time.
Excellent. Piggybacking on that, Sarah, with your work at ACCC and FAN, do you have something you want to contribute to this conversation?
I think that one of the things that I think I'd like to add on to that, I think patient stories and your voice carry so much weight. I think each one of us, and I'm sure Jamie has, a plentiful stories that she can talk about, individual, patient experiences and how, the current, whether their insurance, network, their financial toxicity, and, lack of care, how that impacts, the journey of a patient through their treatment. And I think that it is trying to figure out, like, having resources such as the financial advocacy group at ACCC is wonderful, because one of the things that they do is they pool a lot of resources together that help to train people on how to combat financial toxicity. And they do it through a handful of ways. They have a playbook that teaches, new advocates on how to do this. And as I said before, there's not really, a formal education process for folks that come in, and they may be coming from different backgrounds. I have a pharmacy background, but really access and reimbursement are my passion. It's, I like to try to help those folks get connected. They, ACCC, publishes a patient assistance guide, and it really helps to guide folks through of what to do, as well as webinars and chats that help to keep that information that has been up to date. And one of the other pieces, I think, this through the pandemic and the health crisis that we had last year, we all really talked, and Becky kind of alluded, we've all learned to communicate in a different way, and we've all learned to connect in a different way to kind of populations of folks. But really, at those at-risk populations, we had to figure out how to get to in front of those patients, figure out what they needed. And as the pandemic grew, we knew those needs were going to increase more and more. And so I think that that's one of the things of working with organizations such as ACCC really is going to help to continue to move that needle. As we partner and tell our stories to our partners in Washington and our state houses, so they can make those effective changes.
Thank you, Sarah, very much, and Stuart, very, very compelling. I'd like to ask Jamie a question. I kind of like the symmetry of bookending this. We're nearing the end of our session, and I'd like to start with the fact that was noted at the beginning of our session, and that is that research conducted by PAF indicates that patients living with chronic illness report that they fear financial insolvency and the burden that would place on their families more than they feel dying from their illnesses. And that fact is just so compelling to me personally. And I'd like, Jamie, for you to comment on that from your experience in the field, from what you've seen, is, how is that borne out? And any sort of examples you'd like to share to illustrate would be, I think, a really powerful way to end our time here today.
To families and their loved ones, as we all know, it's definitely a touching subject. It breaks my heart when you go into families' homes and you deal with those families that just cannot afford quality in-home care and advocacy for their loved ones. Speaking with the families, they're afraid to, either leave their loved one at home, or the disabled or aging client is afraid to put a burden on their loved ones. You have the working families that are quitting their jobs, the ones that, can't get a ride to the grocery store, or just the least thing that they need for their loved ones. So when you speak to these families and you hear the stories of them telling, for an example, I have a client now, and he's a younger male, and he's bedridden. His mom is elderly as well, and she helps him at home. And sometimes he lays there with, just no assistance, and he's on our waiting list, and we go out and we help him as we can. But as I said, we can't do it all. My heart breaks when he says things as if, why am I even here? Why am I living? And I try to talk with him as much as I can, advocate for him as much as I can. I went out to disability resource centers, senior care centers, advocating for more services for him. He needs 24-hour care. he needs, and he wants to live a life as well. He participates in the Miracle League, and he has these games every Saturday, and he wants to go out to do that as well. The staff here at Helping Harvest can do some of those things for him. We still, see it our due diligence to help, but we just can't do it all. And, to hear him in the letter that he wrote me about 2 weeks ago, just saying, I appreciate the things that Helping Harvest does for me. And if it wasn't for you guys to step in place, I don't know what I would do. My mom, she can't lift me as she used to. And, I'd rather just not be here. Those are the type of stories that we hear all the time from the disabled community that just want to live a life and cannot afford to get the help and the advocacy and assistance that they need. You guys, it's heartbreaking. And I could tell stories on and on and on, you guys. But in a nutshell, these financial and social needs are devastating almost. There's families that are in need, and there's families that we are leaving, falling through the gap. I mean, not to blame anyone, but just to say, we have to do something. We have to do something to try to provide the quality of care to everyone across the spectrum, regardless of their social background, regardless of the financial standing that they're in. I mean, just because they're disabled or just because they're Asian doesn't mean that they don't deserve the quality of care that we provide. So that's how I piggyback off that, you guys. Thank you.
Very powerful, Jamie. Well, I'd like to thank Sarah and Stuart and Jamie for a really moving panel. I think we've covered sort of a wide swath of what we need to think about as a community in moving this policy action forward. Nicole, I'll send it over to you for final remarks, housekeeping, and anything else. Thank you very much for the opportunity.
Great. Thank you so much, Becky. And thank you to all of our panelists from session 3, as well as throughout the entire day. And appreciate your patience as we work through all of the technical things that pop up throughout a Zoom conference. So just want to remind everyone that tomorrow's session for day 2 will begin at 11:30. If you're interested in our coffee and connections optional networking time to reconnect with others, whether you're a volunteer and you want to speak with other volunteers from different regions, or you're a partner and you want to connect with others as well. We leave that open for your discretion at 11:30 tomorrow Eastern time. And then our first session for the day tomorrow will kick off at noon. So we'll see you back there at around the same time. And again, the rest of the agenda for day 2 is on the slide. We'll have a break around 1:30 Eastern after our session 2, followed by, again, the option to choose between session 3A or 3B for 2 different sessions related to public policy. That will be myself and my colleague, Melissa, or a COVID learning community discussion group. And then finally, session 4 runs from 2:30 to a little bit after 3:15. And day 3 will keep you posted with that agenda as well. And you should have all of the information available in your email. So again, thank you so much to everyone for joining. And we will see you all bright and early tomorrow. Take care, everyone.